जसविंदर सर, कैन यू प्लीज कंफर्म इफ भावसर सर आपके साथ हैं? जसविंदर सर, प्लीज कंफर्म भावसर सर आपके साथ हैं?
हेलो।
हेलो जी सर।
हाँ श्वेता सर, सर ज्वाइन कर रहे हैं अभी।
ओके
Just
ओके,
5
विल
minutes।
वेट विल वेट। All the participants are requested to kindly bear with the delay. Dr. Bhavsar from NACO will join us soon.
Shweta, in the meantime, can you find out how many participants do we have from the state AIDS control societies?
I will check on that, ma'am. Kiran, Dr. Bhavsar sir has joined. Can you please make him co-host? Thank you. Ma'am, is it okay if I start the session and then check the number?
Yeah, sure.
Yeah. Kiran sir, can we start the recording, please?
This meeting is being recorded.
Good afternoon, everyone. iTech India welcomes all the participants for today's discussion on phased out ARV drugs and transition to DTG-based regimens. We thank all the participants and the SACS ART centers for sending in the queries on this topic. We have with us today Dr. S.P. Bhavsar from NACO. Sir is the Deputy Director with CST Division NACO. And we also have with us Dr. Reshu Agarwal, the Public Health Specialist from CDC India. We welcome you both for today's session. I now hand over the session to Dr. Bhavsar, sir, for the opening remarks.
Thank you, dear. Thank you for the introduction. And I welcome you all on behalf of NACO in this session, which is basically on discussion on phased out ARV drugs and transitioning to the DTG-based regimen. So we had in the past had discussions earlier on the phased out drugs and their transitioning to the better and potent DTG-based regimens. But we have also observed that there are many states who are still continuing on the previous regimens, and the medicines are still being given to the PLHIV. So I request you all that all the PLHIVs on those phased out regimens to be transitioned on the newer regimens as been prescribed. So this discussion will be also on based upon the queries that have been received from the ART centers and state control society on various issues pertaining to the transitioning and phasing out from the ARV drugs. So with this remark, I really look forward. This is my first interaction with you all as DD CST division of NACO. And I'm really happy to be with you all in this meeting, and I really look forward for the continuous association with you all. So over to the host and the presentations.
Thank you, sir. I now request Reshu ma'am to please start the session.
Shweta, is my screen
No,
visible?
ma'am. No, you'll have to share it again, ma'am.
Okay, just a minute. Is it fine now?
Yes, ma'am.
Okay, thanks so much. So thanks, Shweta, for the introduction, and thanks, Dr. Bhavsar, for setting the context for this session. And as Dr. Bhavsar laid out that NACO has actually adopted DTG-based regimens in 2020. And since then, a lot of OMs and even the revised guidelines were issued to support the transition and help the states and ART centers in optimization of the ARV drugs. But still, I think NACO is facing problems in terms of the request coming for some of these phased out drugs, or there are still issues like technical queries with DTG transition and what is to be done. So this session is in the same context, and though we had a lot of sessions, NDLS sessions earlier also on DTG transition and also on the phased out drugs, but this is again sort of a recap for those sessions, and we will try to in this session we will basically try to go through the updated ARV regimens in very short, like what is recommended by the national program. And then we will also discuss about the phased out drugs, what regimens and ARV drugs have been phased out from the program. And then as Shweta mentioned, that you all have submitted some queries regarding the transition and the appropriate technical guidelines which needs to be followed in patient management. So in the later half of this session, we will discuss those queries. So just to recap on the regimens, so for first line, you all know that TLD is the preferred first line regimen, and then there are some scenarios where TLD may not be recommended and their alternate regimens may be required, which would be abacavir, lamivudine, and DTG based regimen. And then if the patient is on TB treatment, then 50 milligram additional dose of DTG is required for such patients, and this has to be given 12 hours after the regular dose is given. Also, there are some concerns about the use of DTG in women of childbearing potential, and this we will discuss in more details in the later slides. I'm just like running through these slides and not discuss these slides in great details because we already had multiple discussions on the regimens. So, and this is just to leave these slides or this ready-made material with you as a reference sheet. So, coming to the second line regimen, so you all know that again DTG based regimens are the preferred second line patients, the patients who are not exposed to DTG, and the patients who would be failing on DTG based regimen, for them PI would be preferred, and PI with an NRTI backbone, and this PI would be atazanavir and ritonavir. And I'll not again discuss too much into detail about these slides. And then coming to the third line, this sounds a bit complicated, but then the idea is to use a unused PI plus DTG and the existing NRTI backbone. So this is the principle for the third line, which is being used in the program. And you can go through these slides later if you want, like to get through these details, regimens in more details. So based on whatever regimen are being recommended by the national program as first line, second line, or third line regimen, this slide gives you a snapshot of what are the recommended regimen in the program. So you see, like, there are in total 8 regimens which are being recommended for the adults in the national program. And when I'm saying adult, it means the children above 10 years of age. It includes adolescents and adults. And weighing more than 30 kg in weight. So these are the 8 regimens which are being used or which are being recommended by the national program. And first and foremost is the tenofovir, lamivudine, and dolutegravir. This is available as a fixed dose combination, as you can see in the first row. Then the next is abacavir, lamivudine, and DTG. For this regimen, FDC of abacavir and lamivudine is available, and then it has to be supplemented with DTG 50 milligram. Similarly, for zidovudine, lamivudine, and DTG, ZL combination is available, and DTG 50 milligram has to be added. Then for the second line, the patients who would be failing on DTG based regimen, these patients might need an NRTI backbone plus atazanavir, ritonavir. So the fourth regimen which is recommended in the national program is tenofovir, lamivudine plus atazanavir, ritonavir. And for this, you will have NRTI backbone as FDC, TL, and then atazanavir, ritonavir, which is again available as a FDC. Similarly, ZL TVR, for this ZL as a fixed dose combination, and then atazanavir, ritonavir again as a fixed dose combination. Abacavir, lamivudine, and atazanavir, ritonavir. So again, this is available as fixed dose combination of abacavir, lamivudine, and it has to be complemented by atazanavir, ritonavir fixed dose combination. Then the patients who are exposed to multiple NRTIs might require a PI with DTG and an existing NRTI backbone in their second line as well as in their third line. So for such patients, existing NRTI backbone has to be continued, and this existing NRTI backbone could be TL, AL, or ZL. Then DTG 50 milligram is to be added, and the recommended PI is atazanavir, ritonavir, available as a fixed dose combination. In case the existing NRTI backbone is TL, in those cases you can give TLD to the patients and then complement this with atazanavir, ritonavir fixed dose combination. Similarly, in the patients who are on DTG plus darunavir, ritonavir plus existing NRTI, for them you continue with the existing NRTI backbone, which would be again ZL, AL, or TL, and then complement it with dolutegravir 50 milligram, darunavir 600 milligram, and ritonavir 100 milligram. And again, in such cases, if the existing NRTI backbone is TL, in those cases you can give TLD complemented by darunavir and ritonavir tablets. So this is the gist of all the regimen and the formulations which would be made available under the national program for the adults. So as you could see from the previous slide, like what are the recommended regimens? So this slide reflects the regimen which have been phased out from the national program or which are being phased out from the national program. So you can see TLE, ZLE, ALE, TLN, ALN, ZLN, ZL lopinavir ritonavir, abacavir lopinavir ritonavir, lopinavir ritonavir plus DTG. These regimens are being phased out from the program, and they might be required in some specific cases, but a program will not be doing bulk procurement for these drugs. And accordingly, the drugs which are being phased out, so the drugs which will not be supplied under the national program in the bulk supplies would be TLE, ZLN, efavirenz 600 or the efavirenz adult tablet, nevirapine 200 milligram, lopinavir, ritonavir, fixed dose combination. So these drugs will not be, the bulk procurement for these drugs will not be done. On the SACS recommendations, some specific cases might be requiring these drugs, and on the case basis, local procurement need to be done for these drugs. Coming to the pediatric regimens, so under the national program, there are 4 preferred pediatric regimen, and these are combination of abacavir, lamivudine plus lopinavir ritonavir, or zidovudine, lamivudine with lopinavir ritonavir. Then in the children who are weighing more than 20 kg and have age of more than 6 years, for them DTG based regimen can be used, and these would be abacavir, lamivudine, DTG 50 milligram, or zidovudine, lamivudine plus DTG 50 milligram. And then along with the regimens in the corresponding rows, you see the formulations which are to be used. So when you're giving abacavir, lamivudine, lopinavir, ritonavir to a kid, in those cases, you will use abacavir, lamivudine combination, and there was a detailed guidance which was issued by NACO in this regard. So you could use adult tablet or a pediatric tablet or a combination of all the things based on the weight band of the kid. And this has to be supplemented with lopinavir, ritonavir tablet. The pellets are also made available, and the pellets are to be used for the smaller kids who cannot swallow the tablets. And as soon as the child grows up and is able to swallow whenever feasible, the transitioning of these patients from pellets to the tablets is to be done. So pellets are procured in very small quantity by the national program only for the smaller kids. So this has to be kept in mind, because at times what is happening, once the kid is started on pellets, they continue on pellets for a very long time, even like when they're 5 years or 6 years. So this is not to be done, because this unnecessarily creates problems and the scarcity of the drugs. So coming to the phased out drugs for the pediatric patients. So currently abacavir, lamivudine, efavirenz, That means efavirenz-based regimens are not recommended. So abacavir, lamivudine, and efavirenz, zidovudine, lamivudine, and efavirenz are being phased out. Similarly, nevirapine-based regimen are also being phased out from the pediatric group, and ALN and ZLN and ALN are not to be used any further. So accordingly, the formulations which will not be provided by the national program or which will not be available under the national program would be the pediatric ZLN, efavirenz 200 milligram, and nevirapine 50 milligram. So if there are states participating in this call, please, I will request all the states to please make note that what drugs will not be available under the national program. And if these drugs are required in a very small quantity based on the SACS recommendations, then the procurement has to be done at a local level. But mass procurement at national level or the state level is not recommended for these drugs. So as Dr. Bhavsar was discussing in the beginning, like we are having this discussion because there are still patients on the phased out drugs. So in the previous slides, I clearly described like which regimens are being phased out and which drugs are being phased out. So this is the reporting which is being done by the states, and this is the recent report which is available with the NACO. And what we this slide shows the adult regimen. So what we see in the top row, you see all the regimen which have or the drugs which have been phased out. So TLE, ZLN, efavirenz, nevirapine, lopinavir, ritonavir 250 are either phased out or are being phased out. But what we see that there are still patients on these drugs. So if you see the column for TLE, you still have like a lot of patients in many of the states like Tamil Nadu, Punjab. Still there are patients on these drugs. And then the other issue with the reporting is like there is a mismatch in the number of patients being reported and the consumption being reported. So like for Tripura, you see the number of patients is 240, consumption is 0. So if you don't report properly, all this data has to feed into the forecasting for next year's drug. So if you don't provide correct information, what happens? This information goes into the forecasting tool, and then this deviates or derails the entire forecasted quantity. So I've highlighted a lot of things in yellow. So all the states which are present here, you can please look into these figures. So either your patient number or consumption is not matching, or the number of patients which should be, I mean, ideally there shouldn't be many cases on TLE. TLE is only recommended on a case basis. So you should not have like patients in thousands on TLE. So, and if there are patients on this regimen, please go back to the ART centers and please check like what is the issue and why the patients are still being continued on this regimen, because this regimen would not be provided under the national program. Coming to ZLN, ZLN is I think some quantities of ZLN are currently available and it is being phased out. So till that time the drugs are available, patients are to be continued on this drug. And once the current supply or the current stocks of ZLN exhausts, all the patients need to be transitioned to appropriate regimen. So I'll not discuss this in too much of detail, but please ensure that as soon as the stocks are exhausted, patients should be transitioned to DTG based regimen. Again, efavirenz is again not being recommended under the national guidelines now, and still a lot of states are having multiple patients on these drugs. So this should not be there. And again, I will request all the states to please check their data, because there's a lot of there are three concerns with this. One is you should not have patients on this drug. That is one. Secondly, there is a mismatch in the number of patients you are reporting or the monthly consumption you are reporting. Like for Gujarat is reporting 1,200 patients on efavirenz, but the monthly consumption is 0. So that is not possible. Similarly, if you see I think this is Madhya Pradesh. Sorry, that was not Gujarat, that was Karnataka. And then if you see Madhya Pradesh, so what is happening? Like there are 586 patients and the monthly consumption is nearly 9,000 tablets. So you have to see like even your consumptions are not matching. So if you don't provide exact data, accurate data to NACO, this really defeats the entire purpose of providing appropriate quantities of drugs for the next procurement cycle. Coming to nevirapine, so same is the case with nevirapine. Patients should not be there on nevirapine, and because the patients are being continued on these drugs, the states are sending continuous requirement or continuous request to NACO to supply these drugs. So please note that these drugs would not be supplied by NACO anymore, and states should also not procure these drugs. So especially the states which are highlighted, please check your data. And same is the case with lopinavir ritonavir 250 milligrams. So the guidance was to shift all these patients to atazanavir ritonavir. So all these patients should be shifted to ATVR, and lopinavir ritonavir 250 will not be supplied by the national program. And still a lot of states are having a significant number of patients on this drug. This slide shows the stock for the consumption pattern for the pediatric drugs which are being phased out. So you still see that for ZLN, efavirenz, pediatric, and nevirapine pediatric, there are still patients which are being continued. And again, NACO is receiving continuous requirements or requests from the states to supply these drugs. So please categorically note that these drugs would not be supplied by NACO, and states are not required to procure these drugs even through local procurement. So I think with this, I have completed the first section, which is regarding the recommended regimen in the program and the phased out formulations from the national program. If there are any burning questions, any specific questions, we can take up those questions before we move to the FAQs. And if Dr. Bhavsar or somebody from NACO wants to add something, please do.
Let states or ART centers have anything to say first.
Participants can now unmute their mic and ask questions. Ma'am, we have few questions in the chat box. Children with weight less than 20 kg.
I see technical queries there. So I think because they would be discussed in the FAQs, and if not, we can take them later. So if there are any questions regarding the phased out drugs, I think we should take up those questions right now.
Hello, Dr. Mulu here from NACO.
Yes, sir.
Yes, sir, please go ahead.
Yeah, we have shifted some patients who are on atazanavir regimen to lopinavir ritonavir because of hepatotoxicity related to atazanavir, associated with atazanavir. So how do we go about with these patients who are on the lopinavir ritonavir because of toxicity to atazanavir? Hello?
Yeah, sir, I hope you took a recommendation from SACS in this regard.
Yes,
and that's how you have shifted these patients.
Yes, after
so
we,
yeah, okay.
yeah, after
So
we started the
in
patient.
such case, right. So in such cases, provision for local procurement of lopinavir ritonavir is to be ensured.
Okay. And what about the children who are on lopinavir regimen? When they attain the right weight, do we shift it to dolutegravir or continue with the lopinavir ritonavir?
No. So if they attain right weight, and if there are like more than 20 kgs and 6 years, they can be shifted to DTG based regimen.
All right. Thank you, ma'am.
Hello.
Yeah,
hello,
please go ahead.
Good afternoon, ma'am. I'm Dr. Kawaljit from ART Center, Ropar, Punjab. Ma'am, I have a pediatric patient of age 13-14 years of male, and his weight is less than 25 kgs. He's around 22 kgs, and he's on ZLN peds. So there is very less drugs available for ZLN. So when we can shift him to TLD?
So, since the weight is 25-26 kgs, if I understood correctly.
22, around 22 kgs.
Yeah. Yeah, so TDF, tenofovir is not recommended in such situation. You
Yes,
could
ma'am.
shift this kid to ZLD.
ZLD. Okay, ma'am.
Yeah.
Okay, thank you,
And
ma'am.
once
Thank
the weight improves, and if the child gets the weight of 30 kg, then the child can be shifted to TLD.
Okay, ma'am.
Hello, ma'am.
Okay. Oh,
Hello, ma'am.
thank you.
Yeah.
Hello, ma'am. This is Dr. Vikram from Ahmednagar ART Plus Center. And we have many patients on DTG LPVR. Around 100 patients are there. And if LPVR will be not be supplied by NACO, then what is the alternate regimen for them?
So what is the indication for lopinavir ritonavir for these patients? Why are
Ma'am,
they not on atazanavir ritonavir?
No, the thing was first they were on TLD, then they were shifted to ZLA-TVR, and after that they were shifted to DTGLR. And most of the patients were hepatotoxic or they had nephrotoxicity.
So they were on TLD earlier.
Earlier they were on TLD, and some patients directly had hepatotoxicity
So
and nephrotoxicity.
I think I'll discuss this issue a bit later. Patients don't fail on DTG based regimen that easily. And any switch from DTG based regimen has to be done very judiciously.
Yeah. So in the case, we have a center load of around 7,000 patients, and out of them,
even then,
yeah, only 100 of these are on DTG and LR.
Yeah, so again, I think you'll have to discuss with your state, and a provision for local procurement has to be made.
Yeah. Okay, ma'am. Yes.
Good afternoon, ma'am.
Yeah,
ma'am, I'm Dr. Handa from ART Center, Uttarakhand, Coronation Hospital. I had a query. Ma'am, we have children with weight less than 20 kgs and they're on efavirenz. They are supposed to be on efavirenz 200, but we are giving them efavirenz 600 in pediatric doses. Now, they have not attained the weight band so that they can be given DTG, ma'am. What is to be done in these cases, ma'am?
They need to be shifted to lopinavir ritonavir based ART.
They'll be shifted to, okay, ma'am. LPVR. Ma'am, do we need to take on SACS preference?
If the patients are failing, if they have an unsuppressed viral load, then you have to do a saceprefrel, and if they are suppressed, then you can do the transition on your own.
Okay, thank you, ma'am.
Thank you. So Dr. Bhavsar, do you want to add something here?
Not very specifically. It is very clear from your presentation that we have been repeatedly saying that the adult patients on efavirenz, nevirapine, and LPVR, and pediatrics on efavirenz and nevirapine has to be shifted on the corresponding regimens, as further supplies will not be made. So, as per the request made in present meeting, that there will be a requirement for some selective cases on LPVR, they'll have to make a necessary local procurement and or the necessary societies to ensure that this will be That's all.
Thanks so much, Dr. Bhavsar. So I think we can move to the next section. So I think we've already started getting a lot of questions. So these are the questions which came from the field. So I would try to respond to these questions, and we do have other experts. So if I'm not able to, so maybe other experts can chime in. So the question is it mandatory to have viral load test result within 12 months prior to DTG transition and 6 months following the DTG transition? Ideally, yes. So having a viral load available before transition is something which is recommended. However, if the stock position does not permit you to do that, and if there are low stocks of the current regimen on which the patient is, in such cases, transition can be done without a viral load. And after transitioning, a viral load should be done after 6 months being on DTG based regimen. I think in the same breath, we got the other questions. In patients with unsuppressed viral load and adherence below 95%, is it necessary to repeat the viral load test prior to transition? The other question similar to this was patient is on a phased out regimen with poor adherence and the current regimen is no longer available. Or in cases where LFU patient who was earlier on phased out regimen is tracked back now, and so how do you proceed for the ART management in such cases? So in all such cases, you have to continue, and I'm assuming that you don't have the stocks of the drug on which the patient was is currently which the patient was currently taking or was taking before he became LFU. So that drug supply is not available. If that is available, then obviously you complete the enhanced adherence counseling and you do a repeat viral load test. But in case the supplies of the current drug are not available and there is a need of urgency for transitioning these patients to appropriate regimen, in those cases enhanced adherence counseling or step-up counseling has to be continued and patient should be put on TLD or appropriate regimen, because TLD would be in most cases first line regimen, and if patient requires some other regimen, then a SACS recommendation should be taken. So patient should be put on appropriate DTG based regimen. And for such patients, a viral load should be done at 6 months of DTG initiation or transition, so that you know whether the patient is responding to DTG-based regimen or not. And just to remind you all that the current, as per the current guidelines for the patients who are newly initiated on ART or those who are transitioned to a DTG-based regimen, you have to do a viral load at 6 months and 12 months, and then annually for first line patients, and for second and third line patients, 6 month viral load has to be continued. So why I said like that you can transition the patients even without a viral load, so that there is a lot of data which is coming out from the latest studies, observational studies and programmatic data, and especially one of such big studies, the Nadia trial, and based on these studies, it is being said that even if the viral load is not available, in those cases also transitioning can be done to appropriate DTG-based regimen. And in the Nadia trial, it was also found that TTF containing NRTI backbone was not inferior to switching to the second line regimen. So if a patient was already on, like say, TLE or failing on TLE, or if you compare it with zidovudine based regimen, the patients who were put on TLD, they performed better. The suppression rates were higher in such patients. So based on these available data, in case specific scenarios, transition can be done even if the viral load is not available before transition. Then there are queries about the weight gain and hyperglycemia. Is it a problem after transitioning to DTG-based regimen? I think on this is being debated a lot, and especially about the weight gain. It is found that it is more associated when TAF is given with DTG. So TAF plus DTG are are causing like more issue with the weight gain, and that was evident in the advanced study trial as well as in the Africos trial. Now, this weight gain issue has been found to be multifactorial, and you can see on some of the pictorial depictions on the right side that usually the patients are returning to health. They are like surviving, and usually they are like underweight before ART is initiated, especially if the patients have very low CD4 counts and high HIV viral load before the ART initiation. So obviously they respond to ART better, and they do have some weight gains. Some patients who have like tendency for like obesity might also like report some higher weight gains. Also, like there might be some ART associated phenomena which might be causing some weight gain. So these are some of the multifactorial things which are being studied, and it is currently very difficult to say very concretely like DTG is causing weight gain or it's not causing weight gain. The results which are available currently from the different studies from different programmatic settings, they are showing very heterogeneous results. And it has been observed that there are effects of gender on the weight gain. And it happened that especially in the African population, the women were comparatively more prone to weight gain as compared to men. Also, as I said, patients who were started on ART with very low CD4 counts, or who had a very high HIV RNA, or you can say the patients with very advanced HIV disease, they had a very high prognosis for weight gain. So those are the things which are being currently found. And then the WHO guidelines, they do recommend a multidisciplinary approach and to tackle this issue, especially of the weight gain and hyperglycemia. And it is advisable that you should counsel all your patients for regular exercise and appropriate dietary intakes. And as I said, this is a very debatable issue. Most of the data which is available currently is from African countries. So we need more data from the countries outside Africa and in different populations and geographical regions. So that data is still awaited. Even many of you are part of the study which NACO has commissioned on the adverse effect monitoring, and weight and hyperglycemia monitoring is being done as part of that study also. And hopefully the results from the NACO study would give us some insights like what is happening within the Indian population. So right now, I think my advice would be not to get too much concerned about this issue, but you should counsel all your patients for regular exercise and dietary intake. The other query which has come is if a pregnant woman or a women of childbearing potential is in first trimester, preferred to opt not to take TLD after proper counseling. What are the options available? Or is it safe to give TLD in the first trimester? So on this, I think there are issues of gender equity, gender equality, and the women of childbearing potential or the pregnant women should not be blanketly refused of the benefits of DTG. So DTG is comparatively a very robust regimen. It has comparatively very low side effects. The genetic barrier is really high. And the suppression happens very quickly. In terms of transmission to the baby, the transmission, it really, because it leads to viral load suppression in the women, so the chances of transmission to baby also decreases multifold. And the current data which is available from the SIPAMO study, because if you remember, this was the SIPAMO study which was done in Botswana, which gave or provided some signals about the neural tube defects. But now, as we are progressing, more recent data is also available from this study. And based on the recent data, what we are finding is that the risk is not does not significantly differ from those who are exposed to non-DTG based regimens. So if you compare DTG with other regimen, maybe efavirenz or other non-DTG based regimen, or even with women without HIV, the risk for neural tube defects is does not differ significantly. So the latest data says it is comparatively safe, or it is I mean, if you compare with other ARV drugs, it has the similar consequences or similar impact as compared to efavirenz based regimens for the pregnant women. So this gives some confidence to the providers in using DTG based regimen in the women of childbearing potential as well as in pregnant women. And I think we should keep in mind, whenever we are dealing with the women, we should not solely deprive them of the benefits of DTG. There are a lot of benefits for DTG, and the women should be properly counseled. They should be provided proper information and medical guidance that is appropriate for their situation, and they should be helped in taking a informed decision. So that is the take on this. The other question is about the elevated liver enzyme. AST and ALT gets elevated after switching to DTG-based regimen. So there are certain large clinical trials where the elevations happened more than 3 times, but the proportion of the patient which reported this was very low. It was nearly 2 to 5% of the patients, and it was again comparative, or it could be compared with the patients who were receiving non-DTG based ART. So there is no, again, like no very profound risk of elevated liver enzymes. And usually these elevations were not associated with any clinical symptoms and did not require any dose modifications. So generally speaking, one should not be like too much worried about the elevation of the liver enzymes. But yeah, having said that, if the increase in the liver enzymes is like above 5 times, in those cases the current regimen has to be discontinued, and you can take opinion from SACS about the appropriate ART to be used in such cases. The other question which we received is DTG associated with renal insufficiency. DTG can reduce tubular secretion through inhibition of the OCT2 mechanism, and this can lead to a noticeable, non-pathological, non-progressive increase in serum creatinine with no risk of renal toxicity. So here you should take note that there's no risk of renal toxicity, but there is a non-pathological, non-progressive increase of serum creatinine, and which is not, again, very significant. And in such cases, along with serum creatinine, it might be good to do a urine protein also. I mean, there's if you really have like a very high increase in serum creatinine, then it's something to worry about. But then if there is a slight increase in the creatinine level after starting DTG based regimen, do a urine protein, and that will give you the idea like what is happening and whether the patient is really having a renal toxicity or not. And for PLHIV who are having renal insufficiency or existing illness, no dose adjustment is required except for the days of dialysis, where it has to be given post dialysis. So that's the only thing which you should keep into your mind while dealing with the patients with renal insufficiency. For those failing on DTG following DTG transitioning, is there a likelihood of a mop-up SACS surge as an ad hoc measure and implement on an urgent basis through OM? So I actually didn't get this question very much, but as I was when we were discussing the questions earlier, as I said, it is very unlikely for the patients to fail on DTG based regimen too quickly. And with the data which we are getting from the program, from the ART centers, the suppression rates are really very high. In some of the centers, you're getting a suppression rate to the tune of even 100%, 99.9% also. So if the suppression rates on DTG based regimen in your ART centers are not good, that means that there is some inherent problem with the quality of the services being provided or in the patient's understanding about adherence, and patient is perhaps not adhering to the treatment properly. In some of the structured follow-ups which we did, what we found was like nearly when you do a first viral load of the patients, you get some patients who are unsuppressed. But when you do a very rigorous and careful enhanced adherence counseling, and then after that you do a repeat viral load test, what is happening, nearly 80 to 90% of the patients are getting suppressed. So that means that the step-up counseling or the enhanced adherence counseling in the patients who are failing on DTG based regimen is very critical. It has to be done in a very systematic manner. You have to see whether patient is really adhering to the treatment or not. At times what is happening, patients might be taking partial drugs also, because say patient is on ZL plus D, so might be taking just one drug or might not be taking it simultaneously or at appropriate times. There might be issues when, say, suppose additional DTG is being required, like for TB patients. So patients might have not taken those additional drugs also. So when we actually looked into the issues why patients are failing, what we found there were patients might not be reporting adherence issues, but there were issues with the adherence. Either it was patients were not taking ART properly, or they were taking it partially, and there were some issues with the drug-drug interactions also. Patients taking with the ART with their calcium supplements, multivitamins, or antacids. So that has also been observed. So you have to be like very mindful. If a patient is failing on DTG, you have to look into all possible causes of like non-adherence, or patient is not taking ART properly, or his ART is not getting absorbed properly. So you have to look from that angle, and any failing case or any unsuppressed case of DTG has to be sort of, I'll use the word audited here, that you have to audit your cases. Just don't send these patients to SACP, or just don't without thinking, just don't change the regimen or switch the patient from DTG based regimen. Any switch from DTG based regimen has to be done very judiciously. And the states which are here, or the COEs which are here, I'll request them, because this is the experience which we had in many geographies, that if you do a good enhanced adherence counseling, 80 to 90% of your patients become suppressed again. So please do have a watch on all the failing cases of DTG in your states, and if there are any issues, please flag them and look into the adherence issues and guide the ART centers properly. The next question is PLHIV on DTG plus PI based regimen with TB. In the absence of rifabutin, what regimen is to be given? So again, I will say, for such patients, obviously you cannot give rifampicin. So rifabutin is the preferred regimen, and you can discuss about the availability of the rifabutin and the requirement for your patients with the state TB cell or the district TB cell. In case rifabutin is not available, then non-rifamycin based regimens may be used on a case basis in consultation with the experts. And there were some concerns regarding the availability of the non-rifamycin based regimens. So again, for this, you have to coordinate with your STC or the DTC for the drug availability. For those PLHIV with unsuppressed viral load test results found in either prior or after transition to DTG, can it be made mandatory to have SACP recommendations within a reasonable time frame? So this is not the question regarding the DTG, but the SACP recommendations have to be done in a reasonable time frame, no doubt about it. And the revised ART operational guidelines, they do mention that when a repeat viral load test is done for a patient who has adherence of 95% for 3 consecutive months, for such patients, if these patients are still unsuppressed as per the repeat viral load test, then the SACP referral should be made within 2 days of receiving the viral load test report, and without waiting for the patients to come. And SACP should review these cases and share recommendations with the ART center within 1 week of referral. And simultaneously, patients should be informed to come back to the ART center for regimen switch as recommended by SACP, and same regimen to be continued until the switch is recommended. So there is a very specific guideline on the time frame. So referral has to be made within 2 days of the of receiving the viral load report, and the SACP recommendation has to be done within 1 week. So I'll again request all the COEs, ART plus centers, and state AIDS control societies to look into this issue. The other question which we received is CD4 cannot be done since cartridges are not available, difficult to follow up patients on viral load alone. So here again, I would like to remind you of the revised guidelines. So as per the current guidelines, with the availability of the routine viral load monitoring, CD4 testing can be discontinued in PLHIV except for those with HIV-2 infection when CD4 count is more than 350 cells per millimeter cube and the viral load is suppressed. So in such cases, CD4 testing has to be stopped, and you can rationalize the use of the available CD4 cartridges. New dosing schedule is for new dosing schedule for abacavir lamivudine and zidovudine lamivudine is available, but in weight bands of 20 to 25 kg, we need both pediatric and adult drugs to be given in appropriate dosages. How can we do when we don't have adult? We have only adult AL or ZL. I think in this regard, NACO is trying to restore the supplies of pediatric AL and ZL, and I think the supplies are available with the states and the ART centers now. For the kids less than 10 kg of weight, LPVR pellet syrup has to be given, but both formulation are not available. How to break dosages from pediatric or adult dosage? Again, the supplies are being restored. For pediatric patients of weight less than 20 kg failing on ZL or AL plus lopinavir ritonavir, there is no option available but to wait and watch unless in case of advanced disease. Advanced cases are to be switched to nevirapine or efavirenz based regimen. These are not available under these are not available under the national program now. So can such patients be transferred to COE? Yeah, as I said, like no, these would not be common scenarios. So you might need a nevirapine or efavirenz based regimen for these patients after the consultation with the pediatric SACS or the COE. And in such cases, a provision for local procurement by COE or the SACS has to be done. And this is again a issue for time being only, because NACO is trying to procure DTG 10 milligram in future. So these patients can be switched or shifted to DTG based regimen once DTG 10 mg is available. So this problem will persist until the time DTG 10 mg is available. So for that time, you might need it on a case basis, and local procurements can be done. In case of pediatric patients of weight less than 20 kg failing on AL LPVR or ALE with anemia, what regimen to give? So such patients are to be continued on same regimen till anemia is corrected. So in pediatric patients, you have to try to correct the anemia. And once the anemia is corrected, you can shift these patients to ZLD. And if such patients, sorry for the typo error. So this would be ZL lopinavir ritonavir if the weight is less than 20 kg. And if anemia persists, then obviously you have to consult your pediatric experts. In case of non-availability or serious side effects of LPVR, can ATVR be given specifically in pediatric age group? What is the recommendation dosing schedule according to the weight band? So ATVR can be used for kids who are weighing more than 35 kg. So in such cases, you can do it. For pediatric patients, for changing to DTG-based regimen, if patient is on AL and ALE weight less than 20 kg, what to do? So in such cases, lopinavir ritonavir with appropriate NRTI backbone has to be used, and I explained this earlier also. Once DTG 10 mg is available, then these patients might be shifted to DTG-based regimens. Can darunavir ritonavir based regimen be given to pediatric patients? What is the recommended dosing schedule? Yeah, so darunavir ritonavir can be given to the pediatric patients, especially who are weighing more than 10 kgs. However, in our country, currently the pediatric formulations are not available. So that's basically the barrier here. In case of Hep B co-infection, TDF is to be maintained. But the single drug is not available. So, so TDF as a single drug is being procured by NVHCP, and for the patients who are co-infected with Hep B infection, for them you can coordinate with your counterparts in the NVHCP program, and drug can be provided by them. There's another question about the availability of the single drugs where you have renal insufficiency or lamivudine rash, and you might require single drugs. So I think the guidelines on this are very clear. So that's for such cases, COE or states can procure the drugs, and a referral can be made to COE. You need not do a physical transfer of the patients, but e-referral can be done to the COE. Due to shortage of DTG, PLHIV on ALD and ZLD were shifted to AL plus ATVR or ZL plus ATVR. Now DTG is available. Can we shift again to ALD and ZLD? Yes, that can be done. So now you have comparatively a more optimal drug available for these patients. So these patients should be shifted to DTG-based regimen. With this, I think we have finished all the FAQs which we received before this session. So I'm happy to take up more questions or discussions. Thank you very much, everyone.
Ma'am, I'll just share my screen.
Sure, Shweta, I'll stop sharing.
Good afternoon, madam.
Yeah, good afternoon.
Madam, it was shown here that DTG can reduce tubular secretion and it can cause non-pathologic and non-progressive increase of serum creatinine. If the patient is on TLD, how do we know that the rise in creatinine is due to tenofovir or dolutegravir? How do we differentiate? Is there any method?
So that's what I said. You have to do a urine protein also. So if it's a case of renal toxicity, you will the protein would be there in the urine. Okay. So if you don't get protein in the urine, and if it is just like because usually like in such cases, the change in the serum creatinine values would be very very small change.
Okay.
And it will be non-progressive.
We can continue.
Yeah. But if the but if the protein is there and the change is like comparatively high and it is progressive, then you should think about tenofovir toxicity.
Thank you. One more question. You told us that like CD4 can be discontinued if viral load is less than 1000 and CD4 is more than 350. In the guidelines, it was mentioned that if both are done on the same day, this has to be followed. Should we do the same, or if done on different dates also, can we follow?
See, so this is for the ease of the patient and also the ease of the processes. So ideally, like it is recommended that you do the testing on the same day.
Sometimes,
but if but if it is not done on the same day and like within the same time frame, it is okay.
Maybe 1 or 2 months.
Yeah, that is okay. That is okay. That is okay. If your patient is suppressed, see, yes. Why do you need CD4 in the program? Yes, it's basically to identify the patients with advanced HIV disease.
Yes. And
right?
Viral load is available. We can rely better on viral load.
Yes. So viral load is like comparatively a better monitoring tool.
Yes, madam. And if at all we have CD4 kits available and it's nearing expiry, it may get wasted. That is when we can get it done for others also.
But otherwise, you should prioritize the patients with advanced HIV disease or the patients who are on prophylactic treatment to decide like whether the prophylaxis has to be discontinued.
Viral load because of poor adherence. For them also we can continue.
It doesn't matter actually there. Again, viral load is like better indicator for adherence.
Adherence is poor, no? At least we can get the CD4 done and show them. See, your CD4 is falling. You need to be adhered to your treatment. At least we can use it as a marker to do the counseling, I thought.
Right.
And madam, another small doubt. For darunavir, we don't have to change it to non-rifampicin ATT, right? It is only for PI, not for integrase inhibitors.
Not for DTG. You have to change for darunavir. If the patient is on darunavir, ritonavir plus DTG, then rifabutin is needed. Yeah.
If the patient is on darunavir as well as some other drug, like it does not require any change of ATT, right? The same.
It does. If the patient is on darunavir, then you cannot give rifampicin. You have to give rifabutin.
Oh, for darunavir also, integrase inhibitor.
Yes. Any PI. Darunavir is not an integrase inhibitor. Darunavir is a PI.
Okay. Suddenly I got just well.
Sure. Thank you so much. Yeah, Shweta, you want to go ahead?
Yes, ma'am. Please let me know if the questions have already been discussed. With TLD,
Okay.
some patients are showing altered liver function.
So I think I already discussed this.
Children with weight less than 20 kg and on efavirenz, what should be given? This has been discussed.
Yeah,
Right?
LPVR. Yeah.
Right. Do we need to procure efavirenz 200?
As we discussed, only for the specific cases, like if the patient is failing on LPVR based regimen and is a patient of advanced disease, in such cases, SACS may want to make this recommendation, and then only you might need. But otherwise, generally speaking, efavirenz is not required. Won't be supplied by NACO, and it is not to be procured at local level by the states also for mass use.
What is the reason for phasing out lopinavir, ritonavir?
TRG actually did the toxicity profiling for atazanavir and ritonavir, and when you compare the toxicities of lopinavir ritonavir with atazanavir ritonavir, comparatively the toxicities are higher for lopinavir ritonavir. So that's why ATVR was considered. And secondly, the pill burden for ATVR is comparatively low when you compare with lopinavir ritonavir.
Regarding children on efavirenz 200 as second line, regarding the procurement, this has been answered with the previous one, right?
Yes.
Yeah, as per NACO OM, PLHIV on DTG substituted with attenavir, ritonavir. Now some PLHIV are co-infected with TB and rifabutin is not available. Do we again substitute to a DTG?
Yes. So as I said, like the patients who were like, no, that was a sort of a interim arrangement for these patients. So these patients can be shifted back to DTG based regimen, and especially if they are co-infected, they should be given additional DTG 50 milligram.
Nephrotoxic patients who need reduced dose less than 150 mg daily, when will we get TF or abacavir? What if the patient needs ATD?
So abacavir is recommended for such patients in the national guidelines, and abacavir lamivudine is being procured by the national program as a fixed dose combination. And if the creatinine clearance is more than 30, in those cases, abacavir lamivudine full dose can be used with proper monitoring. However, if it is less than that, then you would need separate tablets of abacavir and lamivudine, and that can be done at a local level.
CD4 cartridges are not available in our center since long. Patient have to pay to get the test done. This was from
I think
ARTC.
I answered that. I answered that.
What about people who are HIV 1 and 2 and HIV 2 positive, old cases among them, and are on lopinavir, ritonavir, need to be shifted to TLD as we are initiating TLD in newly diagnosed HIV 1 and 2 and HIV 2 positive cases.
Yes, all HIV 1 and 2 and HIV 2 cases are to be shifted to DTG based regimen.
If one EAC is done and the patient doesn't come for second and third one, then EAC should be done from the beginning, or the patient can be taken up for step up to from the second EAC.
So when you do a second viral load or a repeat viral load, there should be a 95% adherence for consecutive 3 months. Right?
One patient is on Penergan TDS dose. What to do to get viral suppression? DTG BD or ATVR to give. She is not changed to Lepivil by neurologist. The question is not very clear, ma'am.
Not sure I got the question.
Okay. Right. I'll take her from the chat box then. After starting DTG, most of the patients complained about joint pain.
I think that there is no evidence about this, but if you're getting and is the center part of the AE monitoring, you should report such cases.
A patient has
and for joint pains, I think you should look into other factors also, maybe the age factor or the physical activity or the postural things. So those things are to be considered.
Dr. Swati Jiwane, ma'am, can you please come in for the previous question? Kiran, can you please unmute them? Can you please unmute Dr. Swati, ma'am? Yeah, the next question. After a patient has viral load suppression on phased out regimen, but after transitioning to DTG, viral load has increased. Is it due to DTG failure? If so, what regimen is to be followed?
So usually, as I said, failing on DTG does not happen that easily. So you have to look into the issues about adherence. A very rigorous review of the patient should be done, and patient should be counseled and supported in adhering to the treatment.
Dr. Swati, ma'am?
Yes, ma'am.
Yeah, can
the
you please ask
patient
your
is
question?
epileptic, and she has given phenobarbital, TDS dose 100 milligram. But with the dose, her viral load is between 2000 to 3000, even after she is taking TLD regularly. Because the phenobarbital is a TDS dose, ma'am. Usually it is OD for other patients on epilepsy.
I think I'll have to check on the drug interactions on this.
Okay, ma'am.
Yeah.
With carbamazepine and phenytoin, there is drug interaction with DTG. So other anti-epileptic drugs can be given, like sodium valproate and citalopram. That opinion can be taken from the neurophysician.
But ma'am, in this case, the neurophysician is not changing her epileptic drug.
There's always an alternative. There is always an alternative for us.
Okay, should I send to other neurologists then?
Since you have to write in your referral note that the drug-drug interaction is there between these drugs. These two drugs, either you increase the dose of DTG as per the guideline, or you ask for a change in the anti-epileptic drug.
Okay, ma'am. Thank you.
Excuse me, is it Phenergan or phenobarbital?
Ma'am, Phenergan.
Phenergan is not given for epilepsy, no? Phenobarbital is given.
Yes, ma'am.
I think we have Dr. Rivari also. Sir, do you want to comment on this?
Yes, I think the comment has already come. Good afternoon. That Nargan is antihistaminic only. So we are not talking about phenytoin. Carbamazepine has already been said that if you are taking carbamazepine, the dose has to be, DTG dose has to be increased twice daily.
Thank you, sir.
Thank you, everyone. Ma'am, the next question. Suspected drug-induced hepatitis for TLD. What is the regimen to be substituted?
I think that was also answered already. What is the level of ASALT? It is 3 times, 5 times. How much is the levels? That will decide the change of the regimen. Up to 5 times, you can safely give DTG. 5 times, upper limit of normal.
What will be the guideline for Septran if CD4? Dr. Manmohan Singh, can you please come in? Kiran, can you please mute the mics who are disturbing?
Hello.
Yes,
good
sir.
afternoon. Good afternoon, ma'am. I'm myself pharmacist at ARTBSA.
Yes, sir.
I just want to clarify regarding earlier. It was 350. If CD4 is 350, we are giving Septron below than 350. If CD4 is not being done on regular basis for the old patients, what will be the guideline? We should continue Septron with the viral load suppressed, and what will be the guideline in this regard? Thanks a lot.
So the patients with advanced HIV disease and patients who are on CPT or any other prophylaxis, for them, CD4 count has to be, CD4 monitoring has to be continued. So what I meant was you have to rationalize the use. So for the patients who are like stable and suppressed, and if the CD4 count is less than 350, for these patients, you can discontinue CD4 monitoring.
Ma'am,
Thank
sorry
you,
I
ma'am.
came in late in the meeting because I was busy with the OPD. Just wanted to know whether lopinavir, ritonavir will continue in the program. I hope it is not being phased out.
So lopinavir, ritonavir would be required only for specific cases. NACO will not be doing bulk procurement for these drugs, but however, local procurement at COE level or state level can be done on the
One more
specific requirement.
and one more query, ma'am. A lot of patients with TLD are coming with unmasking of deranged CKD and worsening of diabetes and leading furthermore to CKD. So we have to change them to AL. So increasingly the requirement for AL is in there over a period of time.
So anyways, AL is available in the national program, and I did discuss about the CKD issue and also the weight, the hyperglycemia issues in detail. So you can go through the recording.
Yes, ma'am. Thank you so much.
Ma'am, a few more questions. With TLD, weight gain and type 2 diabetes, noticed few patients, does it require change of regimen? A few patients have been noticed with the weight gain and type 2 diabetes.
No, DTG is not a contraindication for type 2 diabetes or weight gain. So you have to counsel your patients and you can continue with the same regimen.
Is ATVR safe in pregnancy?
For the pregnant women, lopinavir, ritonavir would be preferred.
Integrase strand transfer inhibitor naive subjects taking CBZ should receive DTG 50 mg twice daily versus 1 daily, as is recommended with other potent UGT1A, CYP3A inducers.
I think this was clarified by Dr. Rivari.
Patient is on second line TL-ATVR was sub with TLD according to the OM dated 30th May. Now patient reported with osteoporosis, HLA-B 5701 is positive. So patient can't be taken on AL based regimen. Kindly guide us in this case. You want me to check the person who has put the...
I didn't get the question.
Right.
Yeah,
it's from versus I think sir
TLD
has answered.
can be used. Okay.
Okay. PLHIV with weight less than 35 kg on lopinavir, ritonavir. How to change to atazavir, ritonavir?
On the previous question, can I come
sir.
in?
Yes, sir, please.
When you say osteoporosis, you have to really look into overall picture, why osteoporosis is happening, what is the age, what is the calcium intake, because just tenofovir being only blamed for osteoporosis, yes, that is an important cause if he's on TL, ATVR and then TLD, but you really need to look into osteoporosis issue holistically also, because many people non-PLHIV also have significant osteopenia that can lead to osteoporosis. Because if you go into literature, not very large number of patients will have osteoporosis due to TL. Yes, it is a known side effect, but patient should be evaluated in its full entirety. Thank you.
Thank you, sir. Ma'am, the next question, if CD4 count raised only a little, like 355 after CPT prophylaxis for 6 months, then continue CPT for maintenance. Should CPT be continued for maintenance?
I don't think it needs to be continued if the patient has achieved a count of 350. Rivari sir, do you want to comment on this?
Hello, I got a call. What is the question?
I'll repeat, sir. If CD4 count raised only a little, like 355, after CPT prophylaxis for 6 months, then should CPT be continued for maintenance?
Yes, we should continue. We should keep in mind that there could be 10 to 20% variation in the value. So it is better to continue CPT and do again a repeat CD4 count after 6 months.
The next question, CLHI failed on AL plus lopinavir ritonavir in first line, currently failed on ZLE in second line. Current age is 12 years and weight is 22 kg. Which regimen should be given in third line?
Okay. This case has to be referred to the pediatric COE because obviously the options for third line are very limited. So the pediatric experts will have to take a call on this issue.
And we don't have the pediatric dosage formulations also of third line drugs.
Yeah. So since the weight is 22 kg, TDF cannot be used in such case. So they might have to recycle some NRTI backbone along with DTG. Shweta, do we still have more questions? Because I think I'll have to close this session now.
Ma'am, we have a few questions, but maybe we'll post it by email to you. Is that okay?
Yeah, that would be okay.
Right. Participants are requested to please post their questions to dlcsinfo@itechindia.org, the same email that you received the invite from. You can reply to that email and you can post your questions there. We'll forward it to Reshu ma'am and NACO. Thank you to all the participants for attending today's discussion. Thank you to Reshu ma'am, Dr. Bhavsar sir, Dr. Rewari sir for facilitating this session and for answering all the questions. Ma'am, can we end the session now?
Yes, please. Thank you so much, everyone.
Thank you so much.